Hello. Bismillah, wa salatu wassalam ala ashraf khalqillah. Good evening, everyone. We'd like to welcome everyone back from this coffee break. And now we have the last session of these two lovely and interesting days. And the last session is titled as Oral Communication for MENA and GCC regions. And in this session, I will kindly ask some of the regulators to come to the panel so we can ask them some easy questions. And the question is going to be from two sides. The first side is the chairs of this session, myself, Sultan Al-Dayr from SPMARCO, Dr. Hakima from Hikma, Dr. Balsam from MS Pharma, and Dr. Rabab from Atima. So kindly, I would like to ask Aisha Bamo, a Moroccan regulator, to come to one of these chairs. And also Hajar Filfil from Tunis, Nabil Al-Lawatia, Osama Abdurrahman from GCC, Oman, Ashwaq Qurab from Algeria, and Murad Aydin from Iraq, MOH, Kurdistan region. Please join us on this panel discussion. I would like to ask the audience to use Slido for their questions, and for those who doesn't know how this works, you just look at the back of your badge. You will see how can you write questions on Slido. Of course, we have another option that we can take live questions. That's okay, I think. So, we are still missing 3 regulators. So, yeah, he's So I can announce that. So if there is questions for the Saudi FDA, we have a fresh ex-Saudi FDA person who just left the Saudi FDA. He can tell you what is going on last month, but not this month. So I think we can start. Yeah, I think everyone knows me. So I was an ex-SFDA and it became to be a trend. So we will take the first question. We are looking for mics. Yes, please. Give it to Atma. You have one. So first questions for the regulators is going from the chairs for Dr. Hakima. So this is the first question, obviously. Go ahead.
Perhaps.
Okay.
My first question. My first question for the regulators is a generic question, and I would like really to give us a brief about each country, or your regulation in each country, in Algeria, Tunisia, and all this. What are the regulations? What is the reference of your regulation of bioequivalence? Thank you. Let's start from Ashwaq, please.
Yeah,
thank you.
So we can start.
I'm beginning, excuse my English, I am not in English, fluently English.
That's
I'm
right.
Francophone. I will try answer your question in Arabic. And excuse the Anglophone persons. Alors, احنا بالجزائر عندنا قانون للأدوية، فيه الأدوية الجاهزة، في قانون إنه يتحدث على bioequivalence. القانون ماهوش مدقق، يعني قانون عام، نقول إنه دواء جنيس لازم تكون
وضع ورشة كبيرة يعني في مجال الصحة في الجزائر. يعني حتى الكلمات العربية تروح. اللي ما يعرفوش انه في الجزائر عندنا وكالة الآن، وكالة أدوية في عمرها 2 سنين وما زالت ما هيش في وضع عمل يعني بلان ريجيم كمان 100%. لكن كل ما هو علمي، كل ما هو تقني معروف. يعني احنا عندنا اعضاء وجاوا لهنا بالاردن وتعرفوهم. الاستاذ منصوري عمل عندنا 10 سنين، عملنا تجربه مع المتعاملين الصيدليين في الجزائر، وراحوا الى حد انهم تعاملوا معهم بطريقه جد مقربه ويزانسي ديزيتود هيلب. كانت هناك تجارب مع المتعاملين، وقاموا بتكافؤ حيوي داخل مؤسسة الألانسي يعني المخبر الوطني، باش يقدموا مثال أو يبينوا أنها عملية المقارنة الحيوية مش حاجة غير مقدور عليها. لكن الآن إذا تحدثنا عن القانون في مجال الإداري ما عندناش قانون مدقق. باش نجاوب على السؤال تاعك بطريقة مختصرة، احنا نتبع ECH European Guidelines يدخلونا يعني كيفاش نقولوا دي دوسيي تاع تكافؤ حيوي، ونقوموا بليفالواسيون ونرجعوا يعني المتعاملين نعطوا لهم نتعاملوا معهم بطريقة جد
Okay. So conclusion is Algeria is going to follow the EMA guidelines for bioequivalence. So if companies want to go to Algeria, they have to follow the EMA guidelines. Okay. So we will go to the next regulator, Dr. Osama. I'm sure you have a very interesting update about the GCC regulations.
Osama Abdurrahman, Academia, Germany.
Not a regulator.
At the moment, we applied the GCC in Oman, but I hope in the near future, how near is that, I don't know, we will follow the EMA from A to Z.
So I think this is a critical update for everyone here. There are rumors that the GCC will, or the countries in the GCC will stop working with the GCC guidelines for bioequivalence, and they will ask companies to comply with the EMA guidelines for bioequivalence. I think this is the best for everyone here, so you can conduct one study and go to either Europe or the GCC. But what about the harmonized Arab guidelines?
I mean, when it's come to this date, I don't know when that, it has pro and contra. Has advantage and disadvantage. As example, for the we follow the EMA, that means that BCS class 3 will be included as by waiver for a lot of products. As you know, most of the products, generics, most 33% is class 3. But what is bad for the companies that modified release dosage form, state must be conducted. It's extra study for you. But at least it's agreed guidelines, and I think that for the companies and for the regulatory it's very clear how to deal with each other. This is the benefits of the companies.
Okay, so the next later, Tunis or Morocco?
Tunis.
Dr. Hajar.
Thank you. I'm a quality assessor from the Tunisian Regulatory Authority. First of all, I want to thank Dr. Arabab, Dr. Muhammad for their invitation and all the kindness. For Tunisia, we have already a guidance on bioequivalence, which is published on let's say February 2018, and it will be compulsory by the end of this year. We are in transition phase, So only for the moment, only modified release and immunosuppressors, and the first generic drug of the molecule is compulsory. For the other who have already generic drugs already registered, we don't ask for bioequivalence for those who wanna submit. And by the end of the year, it will be compulsory for all submissions when it is needed. And for the guidance, our Tunisian guide is based on the MENA guidance, the FDA and the WHO. So
Okay.
it's we try to harmonize between all the three instances.
Okay. So basically what you are saying is that you are not asking for bioequivalence from all the products.
Right now.
And I'm sure you did this just to make the products available in your markets. So after some time, it will be compulsory.
Yes,
when
and
you
there is
have
another
all the-
reason.
Yeah,
There is
go
another
ahead.
reason because our law didn't permit experimentation on participants, health volunteers. Since 2015, the law changed, and we have already one CRO, which is
Okay.
before we didn't have CROs, so we choose to postpone the application of the guidance
Okay.
until our national CRO
That's good.
enter into effect.
Okay, so sorry, I have another question since
Yes.
you talked about CROs. So is it compulsory to conduct a study within Tunisia?
No, we don't have this.
Okay, thank you. From Iraq, OH, Kurdistan, Dr. Murad. So what is the situation now?
Regarding our region, the situation is we do follow the Baghdad guidelines, which is they also follow the IMO guidelines for the final registration. But only the difference is in the primary registration we don't ask for the bioequivalence. The drug should be registered under the country of origin. That's the situation.
So basically, the product should be registered in the country of origin, and as a primary registration, I understand that there are two kinds of registration: primary
Primary
and
and
final.
final. The primary only will go for a span of 6 months.
Okay,
In this time,
Yeah.
the company should register it final.
this
And
is
for the final-
just to make the drugs available in the
Just
market.
to make the drug available for
Thank you. I think question now for the audience.
Okay.
Is there a difference between the guidelines in Baghdad and Kurdistan regarding bioequivalence or
They are the same guidelines, but if the drug is registered in Baghdad, already will be registered in Kurdistan. Final.
Yeah,
Final.
but regarding bioequivalence.
And bioequivalence for primary registration in Kurdistan, if the drug is not registered in Baghdad. For primary registration, we don't ask it.
Yeah.
But the drug should be registered and marketed in the country of origin.
Yeah.
And also registered in 2 other countries. Just to register it primary.
Okay.
Thank you.
Good, thank you. Now we will have a question from the audience. I don't think there was a recent question on Slido, so I think we will use the traditional way. Any question from the audience? Now it's your chance.
Last question from a policy point of view. Were there any issues, I mean this question for the whole audience, in Iraq, Kurdistan, and Tunisia, and Algeria, and Oman, I believe, and another regulators in Jordan as well. Were there any issues with hermetic inequivalence in the past? Did they have it? I mean, and how did you handle these issues?
Well, I don't like this question, but we have to answer it. So, well, actually, can I rephrase the question, Dr. Yazid? Was there any generics withdrawn from these markets? No. Thank you. This is the best answer I need. So, is there another question from the audience? Go ahead, Yazid. Sorry. Okay, for this I think we need to go one by one. Yeah.
عندنا يعني مركز
الأعوام الأخيرة بدينا نتعاملوا مع العملاء الصيدليين ونطلبوا منهم كل عميل يكون عنده قسم الفارماكوفيجيلانس، ويعني عندنا مام متعاملين يجيبوا لنا سكي بسور سكي شامس. بالمستشفيات في بالمستشفيات اكيد طبعا هي اكبر عدد من الفارماكوفيجيلانس، يعني اعلانات الفارماكوفيجيلانس تاتي من المستشفيات اكثر من المتعاملين الصيدليين. في مشاكل ويصيبوا الحلول، بعض الاحيان المشكله متعلقه بالدواء، وفي اغلب الاحيان هي مشاكل التعامل مع المرضى، كيف ياخذوا كيف ياخذوا يعني الدواء، متابعه المريض. بعض الاحيان المريض يخرج من المستشفى ويرجع بالاعراض الجانبيه، ولازم يعملوا يعني تحقيق. يعني كل هذا عندنا ومعروف، ويعني المركز عنده اكثر من 20 سنه.
Okay. So Algeria is actually with Uppsala for the WHO, for the pharmacovigilance. Yes. Oman, we know that Oman is the first in establishing the pharmacovigilance system, and recently they asked for Omani pharmacists to handle the pharmacovigilance.
Right, really, we have there is German, very robust and stable pharmacovigilance system, which considered one of the best in this region. We are proud of that.
Thank you.
I will answer on behalf of the Pharmacovigilance Center in Tunisia. They already work with Uppsala, that I know. I have many friends there.
Okay.
And the notification for the pharmacovigilance is very spontaneous and professional one. And it's already quality issues that has been handled and not bioequivalence. It's a matter of quality.
Regarding pharmacovigilance, we have sections for this, and the most of reports come from the hospitals
Okay.
and health centers, not from patients. Most of them are from.
Also, I think the culture doesn't understand yet how to report side effects.
Most of
Because this is a common.
common in Middle
Yeah.
East.
So I think we will have a question from one of the chairs, Dr. Balsa.
Thank you so much for your answer.
No one here.
Thank you so much for joining us. My question.
So,
So, my question is regarding value-added medicine guidelines. Now, as Dr. Ibrahim presented, now JFDA is the first regulatory authority who has issued officially the guidelines, while other authorities still, some are in the drafting stage, or others still are, the idea is not still mature in some countries. So my question is, at which stage each authority is now currently? And also, my concern, or our concern in Jordan, what if we have a value-added medicine which is approved in Jordan, and we want to use this in other authorities? Are the guidelines that JFDA has issued approved by other countries, or will be implemented as is, or there will be any other extra requirement that?
thank you, Dr. Balsam. It's a very important and direct question. Is VAM concept accepted in your country?
يعني في هذا الموضوع انا راح اتكلم بنفسي ماشي بالوزاره ولا بالوكاله. انا شخصيا هذا الفام انا فارماكولوجيست، درت جانبيست. جيت عاملي في الاكاديما وتعلمت مع اكاديما هذا الفاليو ادد ميديسنز. احنا عندنا هذا الترم ما زال ما داولناهش، وأظن إذا كان يعني حبيت تسجلوا الأدوية في الجزائر راح تاخذوا وقت.
So basically she is saying
يعني
no.
القانون يكون قانون عام. لكن ناخذوا تعريف الدواء جنيس، هذا ما استبقش على دواء جنيس، لكن ناخذ دواء انوفيتورز ماهوش دواء يعني راح يكون عمل وبالك تعلموا معكم لان الاسر تتعلم مع المتعاملين الصيدليين مش مع نفسها، ما نقدروش نكونوا مغلوقين، ممكن تجيو وتعلموا معكم وتعلمونا ونمشي مع بعض.
إذا البرودكت is for sure that bioequivalence will not be part of the nomenclature list. Now, if we submit and the product was accepted to be part of the nomenclature list, then it will pass through the normal procedure.
I think there is the value-added medicine as a terminology is not present in all the area, but as a concept, I believe in all countries it's there, because any imported product for you is coming from even Europe or US or any country. If you will register it as is, although for example in US it follows 505(b)(2) and you will it's registered as a new drug, and this is really what is correctly which was also the same. JFA, we would be used to submit these as a new drug without this terminology value-added medicine. But now this really, specific guidelines have been done for such molecules in order to give them extra caution, extra guidelines, extra benefits, extra priorities, extra for the sake of the course industry and the benefit of the industry. Thank you.
يعني هي المشكل يتعدى الوزارة، وكاين الأطباء اللي لازم يتعلموا هذا الترمج. الأطباء يعني راح يكون بالك راح يحدوا من التسريع في التسجيل، لأنه هم الإكسبير كلينيكال إكسبير خبراء الوزارة، لازم هذه الثانية لازم تعلموا معنا وتعلموا معكم باش، لأنه الحد الآن راح يكون
Okay, so I think we should hear from.
So at the moment we don't have MENA guidelines, but we follow the EMA in this matter. We follow also the EMA in such a matter which we are sure. Sometimes we follow also another regulatory authority which we consider them in such a matter. It's very developed. For example, the bioanalytical method verification, which is the US FDA, is more advanced as the EMA. Not all that. We use that. It means as long as there is no guidelines for EMA, we will consider the EMA as our guidelines. I think so. This is my personal advice. This is not, I'm Rahman,
Okay, so I think we have a comment from Dr. Nabila Rahman MOH.
For the value-added medicine, right now we don't have any any forum or anything about this, but we always, the door are open in our regulatory for any necessary drug. So even you can include in this list the shorted drugs also. And all of this medicine, we give them the fast track. So even if a company submit, we will give it a priority, depending on the discussion. So it's not like, it's not meant by this term, but it's there. Okay, yeah. Also I have addition about the pharmacovigilance system in Oman. For the pharma medicines, we follow the system in Oman with the Orsara Center, but also for the biosimilar, actually we want to initiate a new approach. It's not just to take the reports from the doctors or the pharmacists or any care provider. It's also we want to appoint some pharmacists in the hospital to work with the doctors and see the differences between the originator and the biosimilar day by day. So this is the approach, inshallah, we will take it soon.
Thank you, Dr. Nabila. What about Tunis?
In Tunisia right now we launched the approach or the concept of VMA. We consider them already as generic products like other classical ones. And now I will speak as a academic assistant professor at the University of Monastir in Tunisia. I think that there is a value added, really. So maybe we can begin a reflection about the question as soon as possible.
Okay. Dr. Murad.
Regarding bioequivalence, right now we don't have any inquests, of course, but in near future, maybe in a couple of years, we'll start establishing the requirements.
Okay. So I have to conclude here that for us as a pharma companies, we really like to invest and we are sure what are we investing in. I mean, if we are going to invest in a value-added medicines, we need a clear guidance, something that we can rely on in order to do this investment. In Saudi Arabia, sadly, we communicated with the Saudi FDA many times asking them for such guidance like the one issued by the JFDA, and we didn't have any response yet. But we will keep our pressure. For us, this will open many doors for us as a pharma company. And now, I'm sure all of you understand how difficult is the economic situation in the Arab countries. So if we have this opportunity, it will be good for us. So please, as regulators, keep that in your mind. So now we will have a question from the audience. Go ahead.
So, based on my experience in Saudi Arabia, it is not discussed in details the value-added medicine, but it's super generic, or combination of APIs. It is already discussed in the regulatory framework. So, if you have a combinations of new API and the reference product is not registered in combinative therapy, you can submit this application regardless if this combination is registered in FDA or EMA. And it will consider as generic product. If this combination has same strength and indication. But if this combination has different strength or indication, it will be considered as a new non-active substances.
What does it mean, huh?
This is the term in Saudi FDA guidelines, a new known molecule. And really we have an experience with Saudi FDA. We submitted for scientific advice, and it was really, they were so positive. And they referred to EMA guidelines. They are requesting the studies, and it was, but it's that terminology is different. New known molecule.
New molecules mean the same API with a new indication or with a new strength.
So, sorry, Khalid, but at the end of the day, the project was killed, right?
Sorry?
At the end of the day, they killed the project.
I'll keep silent. I would really want to introduce Dr. Aisha from Morocco. She just joined us, and we will repeat the question for her.
We will continue, and after that we can. So we need another question from the audience, please. Go ahead.
Thank you. With the panel on the stage and GFTA and Dr. Nabila from GCC too, within the audience. A few years ago, we had a success story by harmonizing the bioequivalent guideline within the Arab countries. And actually the guideline was issued, and even the ministers of health actually approved that to be considered in all Arab countries. Is it possible, as long as we have regulators from different countries, and as I mentioned, in addition to the stage we have also within the audience, Is it possible actually to have some kind of committee, steering committee with the regulators in order to harmonize also additional guidelines, even or including new topics that evolve like that or others? So we do not reinvent the wheel, like countries that still actually in the phase of developing their own guidelines. It would be much easier for them to adopt or consider what GFDA or GCC actually considered or had in their hands. So this will make the story much easier for you as actually new guideline, but at the same time will make the idea of harmonization much easier. We very much meet every year in this symposium, and again we also would be more than happy to help in any of such meetings within regulators to use or very much to take advantage of the experience of each regulatory authority in that field. So this is actually probably you either answer that or please carry the message to the people in charge back home, because even this is a message I got from His Excellency Dr. Haile that he's really willing to cooperate and collaborate with any Arab agency and to train and provide any help to any Arab country in order to harmonize these guidelines. Just last point, a few years ago when I talked with Professor Bloom about harmonization, I told him I believe that harmonization will be much easier in our region than having harmonization between Europe and US. Simply because Europe and US, each side very much is strict about their regulations, and it will be very hard to change in favor of the other side. While our regulations, we're looking for regulations that scientifically sound right, and we find it okay with industry and with the group, especially that so many countries actually do not have guidelines. When we harmonized the bioequivalence guideline, actually only 3 entities had current guidelines, was Jordan, Egypt, and GCC. Others actually didn't have guidelines, so it was very easy for them to adopt the harmonized guideline. So I hope that we repeat such success story with biosimilars or VAM or any of these new topics.
Thank you very much, Dr. Mohammed. This is a very important intervention from Dr. Mohammed. You are the General Manager of ACDMA, and your executive board are part from the مجلس وزراء الصحة العرب. I think you are a shortcut. يعني إذا ممكن تساعد بهذا الموضوع والكرة في ملعبك. يعني أنت you can help a lot to have the lead في this project. وهذا أكدمه وهذا دورها رائد اللي احنا تعلمنا عليه. فالكرة بملعبك دكتور محمد.
Can I comment on that? Just to clarify, when the harmonized Arab guidelines, before its issuing, Dr. Muhammad was the leader in that. And it was thanks to him and the efforts of many regulators that was issued. And the reason I'm saying that is I was representing the Saudi FDA back then. And it was really a noble idea. And we hope to repeat these success stories with VAM, biosimilars, whatever. Let's try, Dr. Muhammad and Dr. Bloom, let's try to have a session in the next symposium next year about this and invite regulators for these topics. So we have a time for one last question, so it has to be a very good question. So, and if you have comment, go ahead. Comment, then one last question. Please prepare the best question that you can.
Okay. Actually, my colleague Dr. Osama, okay, from Oman, he was always against the idea that we have GCC guidelines and to be with and he was just nagging with me. But alhamdulillah, finally we agreed that, okay, all the guidelines should be harmonized, and to be honest, now we will follow the EMA guidelines. So there will be no more GCC.
Yeah, but
I'm sorry, I have to reply.
I think we can take it on site.
In this case, I have to reply. I don't have anything against harmonization of the guidelines region. What I was considering was really we don't have the resources that applies. We don't have also you know that how many people working in Oman for bioequivalence. You know this in
Sorry, Dr. Osama, but we don't want to waste the time.
Okay, it means that I don't have anything against that at all. I work from any
So, but I think the
contribution in this matter.
idea of issuing harmonized Arab guidelines for BAM or biosimilars, it's a very good idea, and hopefully we will see it one day. Please, regulators, just collaborate with us. So, yeah, okay, I think, is there a question in the audience? No question. Ahmed asked question, go ahead. Yeah.
Now, my last really question regarding, for the authorities regarding the post-approval changes of the products and how really the authorities are considering the bioequivalence. I know that for example, I know the SUPAC and the EMA guidelines, and I know that the level of the change, and for example, for immediate release is different than modified release, and of course, for modified release we go for stringent. So regarding renewal and post-approval changes, I really want to know what are the guidance at your side. Dr. Aisha.
Dr. Aisha from Morocco.
بداية أريد أن أتكلم عن نفسي وعن العمليات المغربي. أشكر اللجنة المنظمة لهذا المؤتمر القيمة وعلى رأسها الدكتور خالد محمد والدكتورة رابعة زيد على حسب الاستقبال وحسن تنظيم وجودة القرارات. I would like to thank ACDIMA for their invitation. A new bioequivalence guideline certified law has been published in Morocco last month, and the regulator gave a grace period until June 2020 to can enforce. Donc there is only one who released by the MOH. And thank you.
So now there is a drafted guidelines in Morocco, right? It's published, yeah. But it's published, is it based on the EMA? So it's based on the WHO guidelines and the JFTA guidelines.
So, yeah, Dr. Aisha, I would like to ask about e-registration. Now, for previously, the bioequivalence was, the previously the bioequivalence was not requested. And now for the e-registration, are you going to request or now the bioequivalence?
So it will be required in renewal, re-registration. Yeah, but I'm sorry, I know regulators doesn't like the question why, but all other regulators doesn't ask for it. Why do you ask for it? So what I'm saying that for re-registration, okay, so I need to ask a question on the other way.
Now, our question, why to be applied on the already registered product?
So I have a product, it's already in the market, in the Moroccan market, and when I come to renew the license of that product, you will ask for a new BE, right?
Yeah, but
It's the... Okay, this BE, should it be in Morocco or in Morocco?
do you have a CRO there in Morocco?
Okay.
So it could be done in this Morocco or outside, and I'm accredited CRO.
Okay. Okay.
Sorry.
Thank you.
Sorry. I just want to answer the question you asked Dr. Aisha. I'm from Morocco.
Welcome.
I will answer this question in my point of view. مش رأي الوزارة ولا المملكة المغربية. في المغرب لوبي كبير للأطباء ومش عايزين يكون في substitution في المغرب. الحكاية أن الوزارة عايزة تعمل هيك جروب اوف جينيركس علشان تحضر السبستيوشن علشان يمكن تكبر الكفرج التأمين الصحي. احنا في المغرب عندنا تقريبا إذا طلعت على الإحصائيات بيقولوا أنه تقريبا 60-70% من المغاربة عندهم تغذية صحية. هاي مش حقيقي إذا رحت الحقيقة في أقل من 40%. كان في تريد أوف. شو نعمل؟ نخفض الأسعار أوكي بس لسه الأوريجينيتورز سعرهم غالي ولسه الحكومة المغربية مش ما عندهاش الإمكانيات اللازمة علشان تكفر all the population. كان الحل شو هو؟ نحط substitution بس لازم نوجد لها لازم نحضرها. عشان نحضرها لازم go forward. الورق مش forward الورق علشان نشوف شو هم نبدأ بالموليكيولز اللي عندهم for chronic disease اللي عندهم therapeutic window صغيرة and so on. نبلش بهم علشان نطلب منهم يحضروا bioequivalence renewal على أساس نقنع الأطباء إنه أوكي الآن في group of generic ولازم تعملوا prescription on the INN اسم العلمي مش اسم البراند. Thank you.
Thank you a lot. So I think we are out of time. So I would like to thank our respected regulators on the panel and in the audience. And also I would like to thank the chairs who prepared the very good questions, controversial questions, but it was very nice. So thank you all.
Thank you very much, Dr. Sata. And if you please give me, let's say, 5 minutes to conclude. When I started making up my mind what I should say at the end of the symposium, I had 3 key points on an empty piece of paper. In the meantime, listening in particular to the last session and talking to some others, the paper is filled up. So it's difficult for me to start, but I'd like to summarize a little bit, but I start out of the protocol, so to say, in congratulating in particular Dr. Satam and the ladies and 1 or 2 males sitting here in front. I was really impressed of this last session. This was very useful and I really admired his way of taming the regulators here, and he is much more a moderator than I am, but I ask for your excuse at the very beginning to accept that I'm an active contributor, but I was really impressed. Congratulations and thanks to all the colleagues sitting here on the panel. So I would like to start with a few observations during the 2 days, and this is very brief, and I have to say I was really deeply impressed of your active participation. That was the highlight for me. But there was also some kind of frustration on my side, the frustration insofar that I was not able to give you enough time for your contributions. That was the backside of the coin, and I think we need to consider that and take this home with us if there would be another occasion to come together here in Jordan. So my conclusions and suggestions, and if I say suggestions, you may understand it also as some kind of preliminary expression of willingness to contribute further on. What we do need is to shorten the program. I think this is something what we have to learn from these 2 days. I think we should shorten it to 3 sessions, plus probably a keynote lecture. This was an experience this time. We have to evaluate whether this is an appropriate approach, but if so, we could reduce the stress with the opening, which normally starts a little bit late and normally takes a little bit longer than scheduled. And if we continue from there with the keynote lecture, I think the first half day would be filled in a positive way. And then in the sessions, probably reduction of the speakers. 3 lectures may be sufficient, and ask the speakers, that's my suggestion to the organizers, even though I'm involved there, and ask the speakers to shorten their presentation to 20 minutes, and 5 minutes question and answer. That means 1.5 hours altogether. Then we could continue, that's just an idea, with a panel discussion among the speakers. They can ask questions among themselves and then open it to a general discussion for an hour. This would give you all the chance to contribute, to comment, to ask questions, to share your experience with the speakers and the regulators. And I think we need enough time for discussion, and the open discussion is probably better than our intention to give everybody the chance to ask the question electronically. I went through it. It's sometimes difficult to understand the point, and if it is communicated verbally, it's easy to ask back to understand it better. And if it's a language problem, English is not, with few exceptions, not our mother tongue, then the question can be asked in Arabic and be translated to the speakers. So this would be easy. Now the most difficult part. I made up my mind what might be interesting topics. And I started with 3, and now my paper is full. And I think after considering the discussion we had yesterday, and Dr. Numa, he asked for Peter for an SOP for developing biorelevant in vitro testing methods. This might be an interesting topic, in particular because we include disintegration in different media and also dissolution. So it could be roadmap to the development of a biopredictive in vitro methodology. And what do you think about locally applied, locally acting products in the GI tract, for example? This might be a topic, so locally topical products, locally applied, locally acting, as we call it in Europe, or non-systemic drugs as it was declared in North America. Another opportunity would be implants and long-acting injectables, which is a challenge. For example, the question which we will discuss in Washington this year, is it necessary to go for repeated application, some kind of multiple dosing, in particular with the long-acting injectables, because they remain in the body and they will release product even at the end of the dosing interval. An interesting topic might also be biphasic releasing products. So the combination of immediate release and modified release product to prolong the action, but have also a rapid onset of action. bioequivalence in patient population, which is a totally different world, oncologic products where you need to go there, and also with some long-acting injectables, you have to go to patients. Metabolite measurement in bioequivalence, where we see still some differences between Europe and the United States, and if you make reference to one of the guidelines, you have to consider also the other, and we need to come to some conclusions here. The value-added medicines topic is a very important one in my eyes. However, I was not sure what the outcome of our discussion today was. Did we really solve any problem? We were happy to understand the Jordan FDA approach better. That was something which is on the positive side. However, we all came to the conclusion that all these issues and all the examples are single cases, and it's a case-by-case decision. And therefore, we may consider to discuss real cases, so examples, not these theoretical assumptions and suggestions and complaints with the regulators. Let's talk about real cases. That might be interesting. What I learned right now, the suggestion of Dr. Saddam, let's talk about a harmonized guideline in this region, could also be a topic. And I have two more cases, two more issues. Post-marketing changes, we discussed that, and the outcome of post-marketing bioequivalence testing. That's a hot topic in my eyes, and very difficult. And you cannot just say, oh, it's easy, we go the same way as doing the approval procedure, because we have to consider that product performance is changing during their lifetime. Not only the generic product, but even more the innovator product. They try to improve it, that's the intention, but if this is done, then they are no more bioequivalent to itself, and what to do then? And therefore, also what to do in case of misperformance of the reference product. So these are the hot topics, and I think we should consider that. That's from an outside view. I'm not living in this region, and of course I have a great sympathy to this region, as you all hopefully recognize. And therefore, I listen carefully what happens here and the problems, and when I'm asked, I give very open my point of view. And if I look on that, I think this is too easy to just say we go that way. I really like any activity to assure that the products on the market remain being bioequivalent. But you cannot only blame the generic and say they changed. If the innovator changed, all of the generic changed. And that is even worse situation. And so we are in one boat in our responsibility to take care of the treatment of the patients, and that should be our motivation for a very open discussion of their issues. And if I can contribute to that, I would be very happy to do so. And I know that from my European colleagues who presented here their talks, they are also willing to do so. So if you like, we would be happy to do so. And that's at the end of my contribution to the conference. Thank you very much again for inviting me, for accepting my way of sometimes a little bit provocative statements. And they are always considered constructively. And thanks for your contribution. And I would like to give the microphone to Dr. Muhammad for the final words.
Thank you. Nice music, by the way. Professor Bloom was a great conclusion, as it was like a great opening of the day as a keynote lecture. Before I thank you all for this conference, let me at least ask you after this conclusion for a photo together, because every time I forget to ask for that, and Dr. Rabab blamed me for that, so I need to mention it the first thing. So please, we can take a photo actually here together. It was actually a great event. Thank you all. I would like to thank, of course, the respected speakers with their exciting and interesting presentations. I would like also to thank the sponsors, Ms. Pharma and Skulak Dawaiya, also to make this event also come true. To thank Dr. Rabab and the organizing committee with all their efforts. And of course, thank you all, the audience, actually, for your patience and active participation, which make actually all of us proud to be with you. So hopefully next year we'll have another great symposium with our chairman for the symposium, and we are always open to your questions or concerns or comments. Hope that also this will open the way and start real collaboration and cooperation among the different regulatory authorities, especially within our region. And so actually we have fruitful results out of such symposiums. Thank you all, and hope to see you next year, inshallah. Thanks a lot. And now please, the photo.